I'm unusual in that I'm the only consultant psychiatrist in psychotherapy who specialises in gender dysphoria in the UK. And I've been doing that for 22 years before it was ever fashionable. And what I've offered is a psychotherapy-only service, an exploratory psychotherapy for anyone who is presenting with some sort of gender confusion or unhappiness about their gender. So I started this 22 years ago in the NHS, and I ran this single-handedly, this clinic, until I left the NHS. 26% of my patients who came to me were post-operative transsexuals who regretted their operations. This was a hidden population. No one had ever asked them whether they were happy or not. They weren't present in any data collection, because there is no data collection. No one's followed up. So this was a hidden population who were suffering, unhappy, and there was nothing out there for them. I don't mind what people do. I want them to be happy. I'm a psychiatrist. I want people to be happy. But I want them to make decisions that they continue to be happy with. And the number of regretters that I've seen who are living in abject misery with bodies that they feel are mutilated, that they don't feel either male or female, it's not to be ignored. One thing I noticed working in gender dysphoria, the gender dysphoria world, was it didn't seem to follow the same model or pattern that any other part of healthcare did. So, for example, I would see a patient for therapy. The patient would be seeing a gender identity clinic for hormones and surgery, but they wouldn't talk to us. I've had patients in therapy for me for a year or two. I've referred them to a gender clinic, because that's what they wanted, and I did prescribe hormones. And not once does the gender clinic ask me my opinion on the patient. I think the patient should actually be suitable for hormones and surgery, but they end up having a sex change. And they haven't asked me, the person who's talked in depth with them. And it doesn't seem to follow. Every other aspect of healthcare is joined up. Why is gender identity clinic, why are they not joined up? Why is it on its own? How can a child know what it is to be a man or woman? When I talk to them, they don't seem to have a very big repertoire of what it is to be a man. You know, when I was growing up, I didn't like rugby, I didn't like this, that and the other. I was still a boy. I was that sort of a boy. But we're veering towards making children feel that they're wrong, whereas what I always say is no body is wrong. You know, if you're not happy with your body, let's help you be happy with your body. The CAS review was much needed. I'm part of a network of clinicians who are all concerned about how gender dysphoria is treated in a very physical, bodily way rather than anything psychological. And so we as a group met with her, I met with her individually, and I don't think she was surprised by what we had to say. It's a medical anomaly in terms of treatment. And I think rather than this very closed shop where kids are being treated for gender but not anything else, even though they may also have autism, depression, trauma, all these things, those are ignored. I think that has to change, and I think we've got to reintegrate children's mental health into being their whole mental health, and not just going, oh, okay, gender problem, gender clinic, nothing else, because we're failing the children otherwise. The false doctrine that we're being led to believe is that they're safe, they're reversible, they'll put a harmless pause on puberty while the child has thinking time, who can then decide what they want to do with their gender. False. The other false narrative is if you don't give a gender-confused child puberty blockers, they're at high risk of suicide. False. No evidence for that. It's repeated again and again. If you repeat something again and again, it almost becomes like fact because you've heard it so many times. It's not fact. There's no evidence. What we do know is puberty blockers are not safe, they're not reversible, and they do have long-term effects. If you stop a child going through puberty, that'll further reinforce, surely, a sense of inadequacy about their own sex and gender. If your peers are going through pubertal changes but you're not, it'll reinforce the fact that you're not quite the same as them. We know that almost 100% of kids who go on puberty blockers then have sex reassignment. So it's a fait accompli. If you give someone a puberty blocker, they're going to have a sex change. So in a way, it's a prelude to it. It's not a pause. And what we also know is that if you're a pre-pubertal boy, this is a bit technical, but if you're a pre-pubertal boy and you haven't gone through puberty, and then you want to then have a sex change, to make a neo-vagina, you've got to invert the penis. You're not going to have a very big vagina because you haven't had a very big penis through puberty. So you have these non-functioning asexual bodies that we're creating. And it's not the happy ever after story that we're led to believe. I think the task following on from the CAS review is, rather than going from one unusual service to lots of little unusual services, is to rethink the whole model completely. In no other branch of medicine or surgery do we apply treatments that there's no evidence for. We need to not just say, well, everyone else is doing it around the world, we will too. We need to be bigger than that. We need to say, what are we doing? What is the purpose? What's the evidence? And what's the safety? These are off-licensed uses of hormone and hormone blockers. They're not licensed for use in children. Why is that? And what is the evidence that this intervention is going to have the benefits you want over a long period of time? There's no follow-up studies. So really ask yourself, if you're the doctor prescribing this unlicensed treatment, or you're the surgeon cutting bits off and rearranging bits, is that the right thing to do? Is it the safe thing to do? Or do we need to start again and think what is best for this child?